Using osimertinib first line, we learned from the FLORA trial, does improve progression-free survival compared to using a first-generation EGFR TKI. The question then is, well, what do you do second line? Because if you use the first generation first, you could use osimertinib second in about half the patients who will develop T790M. If you use osimertinib first, what do you use second? So that is potentially the sequencing challenge. What do you do second? Currently, we don't have an option, I should say, that has been proven to be effective as a second-line targeted therapy after osimertinib. There has been some emerging data that shows that depending on the mechanism of resistance, there may be options in the targeted therapy realm after osimertinib. So if, for instance, a mutation arises in EGFR, a secondary mutation called C797S, potentially a first-generation EGFR inhibitor could be effective after osimertinib. So that's been something that the data has just now been emerging that may be an effective strategy, but it has not really been thoroughly investigated. So it's something that could be considered as an option for patients, but again, has not been really studied very well in a prospective trial, but I think is worth considering for treatment for a patient. I think after osimertinib, a standard treatment probably is chemotherapy, and a consideration could be given to immune therapy as well, which is a whole other discussion about the effectiveness of immune therapy, just much lower in EGFR patients. But I think after osimertinib, it's really thinking about other options besides targeted therapies